Hi, everyone. Thanks for joining the webinar this morning, afternoon, and evening. We will give people a few minutes and then we can get started. Great. Thank you again for joining the final gradient webinar of the year on our critical care webinar series. Today we'll be focusing on pulmonary embolism. This is our 7th webinar of the year. So a big thanks to those who have joined, all or many of them. We really appreciate you sticking with us for this series. I will go through some housekeeping notes in the beginning, and then I'll turn it over to our moderator, Dr. Picho, who will get us started on the session, and then turn it over to the presenters as well. Just a quick welcome and kind of going over some of the functions of Zoom. If you have any questions during the webinar, please use the Q&A function to let us know. We'll be hosting just a Q&A session at the end of the webinar as well. So feel free to keep your questions till then. The webinar will be recorded. You'll receive a copy of the recording after the webinar via email. It'll also be available on our website, gradienthealth.org, under our training page, and our YouTube page as well. And then finally, if you'd like to share any feedback, especially any topics you'd like for us to cover next year, please send us an email at customers@gradienthealth.org. We love to hear the feedback and see if there are any specific topics that we can help cover in the new year. And with that, I will turn it over to our moderator, Dr. Papicho, to introduce the panelists and get us started.
Thank you very much, Mariam. And I welcome all our participants to this webinar on pulmonary embolism. As it was said, pulmonary embolism is a great cause of morbidity and mortality in our hospital. Usually it goes unknown by lack of knowledge or ignorance of clinical features or predisposing factors to pick it up on different type of patients. That is how it was decided to go through this topic today. And this will be some of the objectives that we are going to discuss during today's session. The first objective will be to enumerate the common the common risk factors associated with pulmonary embolism. The second objective, to discuss the physiopathology of pulmonary embolism. Third, to list common presenting features for pulmonary embolism. Fourth objective, to discuss diagnostic criteria, scoring systems, and classifications of pulmonary embolism. Fifth, to outline management principles of pulmonary embolism. And sixth, to outline prevention strategies in a hospital setup. To discuss today's topics, we have our great two clinicians, Dr. Appy and Dr. Roger. To kick off our presentation, Dr. Appy will pick it up and then she'll introduce the topic and carry on until a certain point. Dr. Roger will continue and end the presentation. Please stay focused and listen to the grateful presenters who are here to discuss with us this topic. Dr. Appy, you are welcome, Doc.
Thank you, Papicho. As I've been introduced, my name is Happiness Swai, anesthesiologist working at KCMC Hospital. I'll take you through the first part of our presentation. And before I start, I'll read to you a clinical case scenario. So I'm asking for your attention as I'm going to read this case once, and we are going to meet it at different points in my presentations, and there are questions to answer from this scenario. So clinical case scenario, a 36-year-old female presented to casualty with a breathing difficulty of 1 hour duration. She had just landed at the airport after an 18 hours flight, wheeled into emergency unit where the saturation was 76%, the heart rate 108 beats per minute, and the blood pressure 90/70 millimeters of mercury. On chest auscultation, there were no added sounds. A 12-lead ECG showed sinus tachycardia with right axis deviation. Echo showed normal right-sided chambers with mild to moderate tricuspid regurgitation. And an X-ray was also done, which was normal, but she revealed that she has been taking oral contraceptives since after giving birth 6 months ago. So how are you going to approach this patient? Like, how are you going to manage this patient? So please summarize your answers in the chat box. Next slide. So epidemiology and burden of pulmonary embolism. So literature shows that venous thromboembolism is responsible for hospitalization of about 250,000 Americans annual, with a significant risk for morbidity and mortality. And studies in Africa shows that the prevalence of pulmonary embolism in medical patients is up to 61.5%, with a mortality rate of about 69.5%. And in a surgical patient, the case fatality rate was 60. So massive pulmonary embolism is second only to sudden cardiac death as a cause of sudden death. But despite the recent advances in diagnostic capabilities, there is delay in diagnosis of pulmonary embolism, and most often the diagnosis is missed and is done, we normally diagnose these patients, the pulmonary embolism in autopsy. So why is it missed? One of the reasons is due to its presenting non-specific signs and symptoms, and sometimes it presents with no symptoms. And that was a study which was done in the US on autopsy, which showed that 60% of the patients who died had pulmonary embolism, with the diagnosis having been missed in up to 70% of the cases. So from this epidemiology, as we can see, the burden of the disease is really huge, especially in our setting. That's why we thought it is important to talk about it. Next. So by definition, first of all, pulmonary embolism is not a disease in and of itself. Rather, it's a complication of underlying medical condition, and the usual is from the complication of venous thromboembolism. So pulmonary embolism happens when a blood-borne substance becomes lodged in the branch of pulmonary artery and obstruct the blood flow to the lungs. So as I said, the most common cause of this embolism is from the DVT, deep vein thrombosis, especially of the lower extremity. And these pictures here shows an emboli, which is the thrombus, which is traveling from the lower extremities, and it is entering into the right side of the heart through the inferior vena cava into the right atrium, then to the right ventricle, and then it goes to the pulmonary circulation. As we can see here, we can see the embolus, which is the thrombus, which has been lodged into these pulmonary artery branches. And mostly it affects the lower zones of the lungs because of the gravity. More blood flows to the lower zones of the lungs. Next slide, please. So sources for embolus are multiple. As I said, the most common one is the thrombus, but another source of emboli could be the air, and air can enter into the vessels when injected accidental, but also when it can arise from the divers. So divers the divers, when they rise up quickly from the water, due to the pressure changes, an embolus can develop, and it enters into the circulation. But it can also be fat, and fat can result from the injured pelvic bones or long bones. But the sources can be amniotic fluid, which enters the maternal circulation, but it can also be bacteria, which we call septic emboli, or it can also result from the tumor cells, whereby we say the tumor embolies. Next slide, please. Etiology. So the calf vein thromboembolism is one of the most common cause of pulmonary embolism. So can originate anywhere from the lower extremity, so it can be but it can originate anywhere. So it can arise from the pelvic veins, it can arise from the renal veins, also it can arise from the heart, and also it can arise from the upper extremities. So the presence of DVT usually is unsuspected until embolism occurs. Next slide. Etiology. So as I said, almost all pulmonary embolism are thrombi arising from the deep vein thrombosis. And what causes this thrombi, or what causes the blood clot? So from the Vickers triad, just as the name says, triad means it's a group of 3 factors which cause blood clot to develop within the deep veins. So one of the factors could be the stasis or abnormal flow of the blood. So for normal, the blood has to flow back to the heart via the veins, via the veins, with the aid of the valves in the muscle movement. For example, the contraction of the muscles help to squeeze the blood back to the heart. But when there is either the muscle are not they're not working, or they're not being used, or maybe the vein valves are not working, so the stasis can occur and it can cause the blood clot. For example, in immobilized patient, or patient who has paralysis, or the patient who have varicose vein. So in patient who have varicose vein, there's issues with the vein valves, but also the surgical patient, they can be mobilized because of the surgery. And also patients who are traveling, who have long travel, more than 80 hours, so they stay without moving the extremities for long, and it can predispose them to develop thrombus. And also the stasis can occur due to obstruction, for example, in pregnant. So the gravity uterus can obstruct the pelvic veins and cause the blood stasis and health development of the thrombus. But also it could be maybe the heart atrial fibrillation can also cause the formation of thrombus. But the other reason is endothelial damage. So with the endothelial damage, we all know that once we have endothelial damage, it stimulates the coagulation cascade, and the damage can be caused by the surgery. Major surgeries involve cutting of the vessels, which can stimulate the coagulation cascade, but it can be through the IV drug usage. For example, when you are using you are putting maybe IV cannula, now you traumatize the vessel, and then the coagulation cascade can happen. But also it can be through indwelling devices. For example, the central line can cause trauma to the vessel and cause the coagulation cascade. But the other thing could be the hypercoagulability state. So in hypercoagulability state, it means there is imbalance between procoagulant enzymes and anticoagulant enzymes, and most commonly is from the genetic defects. But it can also happen due to use of some of the drugs. For example, use of estrogen increase the procoagulant enzymes, and some of use of these antipsychotic drugs, atypical ones, can also cause the hypercoagulability state. But you might be managing the patient who has pulmonary embolism with heparin, and that patient developed the heparin-induced thrombocytopenia, which can even worsen the condition. Next slide, please. So predisposing factors. So why do we want to know about the predisposing factors? So as we have seen that most of this pulmonary embolism, the diagnosis is always missed. And if it's done late. So for you to diagnose pulmonary embolism, you need to think about it. And things which will give you clue about the pulmonary embolism, so you need to know the risk factors. So risk factors are going to give you clues about the pulmonary embolism, and if you think about it, you are going to order specific investigations to it, and you'll be able to diagnose it. So there is extensive collection of predisposing environment and genetic factors, and there is interaction between patient-related factors, which we call the permanent factors, things like the genetic mutations, and the setting-related factors, which we call the temporary factors, things like immobilization, etc. But this venous thromboembolism is considered to be provoked if there is presence of temporary or reversible factors within 6 to 3 months before diagnosis. But if no these factors, no these reversible factors, it's called unprovoked. So the presence of permanent factors can affect the duration of anticoagulation therapy after the pulmonary embolism. So you need to know the risk factors because it will also affect the management. Next. Again, going to proceeding the predisposing factors. So most of these I've mentioned them through the VCOD triad. So issues of immobilization. So immobilization, as we have seen, can be due to long hour traveling. So someone is traveling for more than 8 hours is a risk factor. Could be maybe the reason for immobilization can be surgery. Media surgeries, these patients are going to be mobile for some times. So it's a risk factor for them to develop embolism. And also could be maybe they have trauma to the lower limb, or they have spinal cord injury, they have paralysis, they are becoming immobile because they're paralyzed. So it's a risk factor. But other risk factor could be the malignance. So they are malignant of hematological malignants, lung, gastrointestinal, and brain tumors have high risk of causing thrombi. But again, the medication usage, as you have seen, oral contraceptive pills and antipsychotic drugs, they increase the procoagulant factors and provoke the coagulation. And also could be the inherited causes, so issues of the gene mutation, and the most common is factor V mutation, and also deficiency of antithrombin 3, protein C and S. But there are other reasons, issues of myocardial infarction, issues of heart failure, issues of autoimmune diseases. All these can predispose someone to get thromboembolism. Next, please. So again, back to our case. I hope we all remember the case. So do you have any predisposing factors in this case? And is it considered to be provoked or unprovoked? Please share your answers in the chat box. Next, please. So pathophysiology of pulmonary embolism. So what happens when you have a pulmonary embolism? So once you have pulmonary embolism, and you have, as we have seen, that the most common cause of the embolism is the thrombus, and the thrombus itself contains a lot of platelets, and this can cause release of these chemicals, the serotonin and thromboxane A2, and this causes the vascular constriction, pulmonary vascular constriction. And when you have pulmonary vascular constriction, it causes increase of pulmonary vascular resistance. And once you have increase of pulmonary vascular resistance, you will have increased right ventricular afterload. And once you have increase in right ventricular afterload, you will have right ventricular dilatation and right ventricular dysfunction, because the right ventricle needs to work so hard so as to overcome the resistance. And also you end up getting decreased coronal blood flow, so the myocardial ischemia. So once this right side of the heart is affected, it's also going to affect the left side of the heart. So on the left side of the heart, you are going to have the reduced stroke volume, and you are going to have the reduced cardiac output. And at the end, you are going to have reduced systemic blood pressure, and you can end up getting the hypotension. Next slide, please. So this is talking the same thing, but here what is added is this cardiogenic shock. So the shock which you get here is cardiogenic shock, and if you will not manage it, you'll end up into death. Next slide. So again, back to our case. So our patient had respiratory distress with severe hypoxemia, was tachypneic and tachycardic. The blood pressure was unstable and there is no clinical findings suggestive of myocardial infarction or COPD or tamponade. So how do you assess the severity of pulmonary embolism in this patient? So as well, share your answers in the chat box. Next slide. So clinical features of pulmonary embolism. So how will the patient having pulmonary embolism present? So pulmonary embolism is suspected on the basis of acute onset of dyspnea. So they get dyspnea because they get hypoxemia. So once you have hypoxemia and dyspnea happens, and also they present with chest pain, but the chest pain is caused by pleural irritation due to distal emboli causing pulmonary infarction. In the classical presentation of this pain, they get pain when they take in the breath, when they inhale. They can also present with the syncope. Why syncope? Because we have seen these patients, they end up getting hypotension, low perfusion to the brain, and they end up having the syncope. And also they present with, they may present with the hemoptysis. Why hemoptysis? Because of infection to the lungs, which can cause rupture of capillary membranes, and then they can cough up blood. So hypotension and shock are late stage manifestation, and they indicate central pulmonary embolism or severe reduced hemodynamic reserve. So pulmonary embolism may be completely asymptomatic and may be discovered incidental during diagnostic workup for another diseases or at autopsy. Next slide, please. So clinical features based on severity. The American Heart Association has clinical classified pulmonary embolism into massive, submassive, and minor or non-massive pulmonary embolism. So in massive pulmonary embolism is when there is sustained hypotension, the systolic blood pressure less than 90 millimeters of mercury for more or equal to 15 minutes. Also, when this patient needs nootropic support, or when there is pulselessness, and also when there is persistent profound bradycardia, heart rate less than 40 beats per minute with the signs or symptoms of shock. And this patient with massive pulmonary embolism are at high risk of ending up into mortality. So the other type is submissive. So back to the previous slide. Submissive pulmonary embolism. So here there is this patient is systemical normotensive with systolic blood pressure of more or equal to 90 millimeters of mercury. They have right ventricular dysfunction and also myocardial infarction or necrosis. And the risk here is moderate to intermediate. In the minor or non-massive pulmonary embolism is when they are systemical normotensive with the systolic blood pressure of more or equal to 90 millimeters of mercury, but there is no right ventricular dysfunction or myocardial infarction. Next slide. So as I said earlier, the pulmonary embolism, the cause of pulmonary embolism, the most common cause is the thrombus, but there are non-thrombotic causes of pulmonary embolism. So different cell types can cause non-thrombotic embolization. So the fat tissues, the amniotic fluid, trophoblastic and tumor cells can cause the embolism. But in addition, the bacterial, the fungi, parasites, foreign materials, and gas can lead to pulmonary embolism. But diagnosis of non-thrombotic pulmonary embolism can be challenged, and in case of small particles, microemboli cannot be detected on the CT images. So it's difficult sometimes to diagnose this non-thrombotic pulmonary embolism. Next slide. So one of the non-thrombotic pulmonary embolism is septic emboli. So this is relatively rare clinical event commonly associated with right-sided endocarditis. So this happens most commonly in patients with endocarditis. And the risk factors are intravenous drug abuse, or maybe infected indwelling catheters or pacemaker wires, but also can arise from septic thrombophlebitis from the tonsils and the jugular, dental, and pelvic regions. So diagnosis is through identifying the source of septic emboli and also do blood culture test and chest X-ray OCT after considering the clinical context. So the treatment here is specifically for the responsible organism. So once you do a blood culture test, you can know the causative organism and then you can treat it. Next slide. So another cause is foreign material pulmonary embolism. So the increasing use of intervention techniques in modern medicine has drastically increased the incidence of foreign material pulmonary embolism. So the sources here can be the silicone, broken catheters, can be the guide wires, maybe when you are putting the central line, so wire can accidentally goes into the right side of the heart and cause it goes to the pulmonary circulation and cause the embolism. But it can also be the vena cava filter. So sometimes you may be treating the pulmonary embolism and then it complicates and cause more obstruction, but can also result from the cause of embolization in the endovascular stent component. So if possible, the management here is to remove the foreign object, since the material may cause further thrombosis and sepsis. Next slide, please. So another cause is fat emboli, and occurs almost on all patients with pelvic and long bone fractures in those undergoing endomedullary and joint replacement surgeries. But other causes can be through the lipid and propofol infusion. Also can be through intraosseous infusion and bone marrow harvest, and in sickle cell diseases. So patient also with fat liver disease, pancreatitis, and after liposuctioning. But the classical triad presentation of fat embolism is, the first one is altered mental status, but can also present with the respiratory distress and petechial rash occurring typical 12 to 36 hours after the injury. But fat embolism is self-limiting and the treatment should be supportive. So you treat what the patient is presenting with. Although the successful use of high dose of methylprednisolone has been reported in human. Next slide, please. So another source is air embolism. So air embolism can occur both in venous and arterial system, but most commonly it occurs on the venous system. So venous air embolism is often an iatrogenic complication of manipulation of central venous and hemodialysis catheters. But as I said earlier, it can also happen to the divers. So once they rise up quickly due to the changes of pressure, an emboli can be formed and enters in the circulation. And the lethal volume of air that is ranging from 100 to 500 mils. So once you have 100 to 500 mils in your circulation, so it's high risk, like you can end up in major complications. And the major effect of venous air embolism is the obstruction of the right ventricular outflow tract or the pulmonary arterioles by mixture of air bubbles and fibrin. Next slide. So diagnosis of air embolism. So an X-ray or echocardiogram and the CT scan can be done, but CT scan is the most sensitive diagnostic test showing a unique picture of round or mirror-shaped densities localized ventrally in supine patient. And the treatment for air embolism is, first one is maintenance of circulation, prevention of further entry of gas and volume expansion. So the patient should be placed in left lateral decubitus position to prevent right ventricular outflow obstruction by the airlock. But in case of large amount of central air, so you can do aspiration through the central venous catheter. Administration of up to 100% oxygen can decrease the bubble size by establishing a diffusion gradient that favors elimination of the gas. Next slide, please. Another cause of non-thrombotic pulmonary embolism is amniotic fluid. It's a rare but catastrophic complication unique to pregnancy, so it occurs only to pregnant women. In 1 to 3 cases of 100,000 pregnancies, so the occurrence, like in 100,000 cases, 2 to 3 patients can get amniotic fluid embolism. Likely mechanism is that amniotic fluid enters in the uterine veins during normal labor or when the placenta is disrupted by surgery or trauma. As a consequence, pulmonary vessels are obstructed by the cell groups and the meconium, and an inflammatory reaction occurs due to release of active metabolites. So the presentation, the patient can present with seizures. Some patients can be diagnosed with pulmonary edema and the ARDS late in the course. So the treatment here as well is supportive, but mortality is high, is up to 21%. Next slide. So types of pulmonary embolism based on location. So we have pseudo-pulmonary embolism. So in pseudo-pulmonary embolism, there's large clot into the pulmonary artery, but the other type is lobar pulmonary embolism when the clot is into the big branch of pulmonary artery, but the other type is distal pulmonary embolism when we have a clot into the small branches of pulmonary artery. Next slide, please. So this marks the end of my part. Thank you very much for listening.
Thank you very much, Dr. Happy. Wonderful presentation. We're going to continue with Dr. Roger, who's going to talk to us about the approach, management, and investigation to do. We also encourage our great participants, and we are very grateful for their active participation in the chat box. This is really showing that they are very attentive and following the presentation. Keep it up as Dr. Roger is taking us into the next part of the presentation. Doc, please, you're on the floor.
Okay, thank you very much. My name is Roger, as it's been introduced. And next slide, please. Can everyone hear me?
Yes, we can hear you.
Yes.
Okay. Next slide, please. So here we'll look at the various scoring systems. And the scoring system offers to determine the probability of a PE. Once we see a patient, what guides us to be able to think like this is a PE, this is a patient with a pulmonary embolism. And we'll look, these tools also aid us in the diagnostic workup, like, okay, what should we do to diagnose the PE? And also these tools offer an assessment of severity of the pulmonary embolism. But we might as well be able to do risk stratification. That means we want to know what's the mortality, what's the prognosis of this patient. Is this patient high-risk patient that may not have a good outcome, or is this patient with a good probability of having a good outcome? So the tools will help us determine all those above, and we'll look at a few of the tools and we'll continue with the management. Next slide, please. So we have different scoring systems. We have Pulmonary Embolism Severity Index, PES. We have a Miller Index, and we have a famous Wells scoring system. We have a revised Geneva scoring system, and the PERC, the Pulmonary Embolism Rule-Out Criteria, but there are also others, Charlotte and Miniat rule. So we'll look at mainly 3, which I think will help us to be able to understand. We'll look at the PES, Pulmonary Embolism Severity Score. We'll look at the Miller's, and we'll also talk more about wells, and we might look a bit about the PERC. So PES, can we go to the next slide, please? So PES, the aim of this score is to help us to predict 30 days outcome of a patient with a pulmonary embolism. So you can look at the variables on the right, that we have age, a patient with cancer, a patient with a cardiopulmonary disease, a patient who presents with a pulse rate more than 110 per minute, also systolic blood pressure less than 100 millimeters of mercury, or a patient with a desaturating less than 90. So once the patient, the PES, actually the patient is already having a pulmonary embolism. So we want to be able to score this patient to know what are the outcomes. So we can look if the score, if they have less than 1%, then basically it means that they are low risk patients. If they have 3 to 15%, then it's intermediate risk. But if it's above 15%, then this is high risk patients, that it means the outcome in 30 days might be poor. So each of the 6 variables scores 1, and each of it can give us that percentage. Can we go to the next slide, please? So Miller index, it's mostly done by the, if you have a bit of knowledge on how to interpret a CT scan, and it helps us to be able to quantify the obstruction on the CT scan. So the radiologist can be better at interpreting it, but also as a practitioner or a physician, should be able to have the knowledge to see and be able at least to have a glimpse that this is an obstruction and this is causing a pulmonary embolism. So we may not look at this into more details, but this is the glimpse. When you hear about Miller index, let's understand that, okay, this is talking about the pulmonary embolism, the obstruction seen on the CT scan. Can we go to the next slide? Next slide again. Next slide. So this is Wells scoring system. So Wells is the famous scoring system that we use as physicians and practitioners. And this is it helps us to be able to decide if this patient has the probability of having a PE or not. And we usually try to use it in any patient that is hospitalized, that has been in the hospital for quite some time. So you think of this patient and your likelihood of doing further investigations to rule out or to rule in PE. It does not rule out, but it rules in PE. So you find that Wells score as something on the criteria. There's one of embolism in the DVT in the past. So there's Wells to be able to help us to determine if a patient has DVT, but also Wells can help us to determine if a patient has a PE. So we want to think of a patient who has been immobilized, has been hospitalized in the bed for more than 3 days, or has had surgery in the past 4 weeks. Is this patient a cancer patient? Is this patient diagnosed in the DVT in one of the legs? Does this patient has a history of embolism in the past? Does this patient present with hemoptysis? That means they cough blood in the sputum. Is this patient tachycardic? So if they have 1, 2 of these, like 2 score, then in your mind, you'd start to think of pulmonary embolism. So whenever you're doing your rounds and you see a patient who has been hospitalized for more than 3 days, and now is complaining of leg pain in one of the leg pains, and maybe you have done your Doppler and you find that they have the DVT, then obviously you have to start thinking that this patient might be having a PE. So this Wells score helps us to rule in PE in any patient that has been hospitalized. So we can also use or apply the Wells score even in the emergency or bedridden maybe for, it's an old patient in bed. They've been in bed and now they're presenting with symptoms of coughing blood. Then if you see that, you have to think that this patient is likely, most likely having a PE. So you must be able to further investigations through in PE throughout. It's an important that we can use and apply it in our daily rounds and as we see patients in various stations where we are. Next slide, please. So sometimes you might be thinking that this patient has a PE or not. And now it's when we come to the PEC or pulmonary embolism. is a criteria that we use to rule out that it shows it gives us specificity that the patient is negative for PE. And for a patient to be negative for PE, or there's still that, the acronym that we're using in medicine, we usually like to use acronyms so easy for us to remember the mnemonics. So still, S stands for surgery, T stands for trauma. Is this patient having any history of surgery? Is it patient who had just been from surgery? Is this patient from trauma? Is this patient using estrogen? What is the arterial saturation? That means you have to do an EBG. Are they low or normal? Does this patient present with any leg swelling? Is this patient tachycardic? What's the age of this patient? And does this patient present with any thrombosis? If any of that is positive, then we're not ruling out TPE. We have to think of PE. But if all of the above are negative, that means they are no, then the likelihood of getting PE is very low. So at times that you might have a patient in the emergency department presenting with tachycardia or desaturation, and you're worrying, is this patient having PE or not? You can remember to use the PEC, and this will help you to guide you like, okay, within my PEC, this patient, the likelihood of PE is very low, then I don't have to do further studies or investigations for this patient. But if any of this is positive, then that means you have to do further studies to rule in PE for this particular patient. Next slide. So we can see all this, and we can see on this slide the comments. I want you to focus on the comments. So sometimes the patient may present in the emergency department, not tachycardic, but you're thinking of PE. If the patient is on beta blockers, then it means they might have normal heart rate because of the beta blockers that they've been using or recently have taken the beta blockers. So you have to think that, okay, yes, the patient is not presenting with tachycardia, but still they might have PE. If your clinical suspicious of PE is there, sometimes it's important to remember all these comments. If they're on beta blockers, then disregard the heart rate. For a patient who is maybe a COPD patient, who is a chronic COPD patient, then obvious, you know that they're already used to hypoxia state, so the oxygen saturation may not be high. If a patient is amputated, then you don't expect them to have any lower limb swelling. So you don't even have to think about the lower limb swelling or anything. So you have to remember the comments and not just focus. The patient does not have tachycardia, so this is negative for PEC. It can still be positive just because they're on the beta blocker. So it's important to remember all these negatives, these comments, to consider them whenever you want to use the PEC to rule out PE. Next slide, please. So whenever you have a vague situation, non-specific symptoms, just maintain your high level of suspicion. And this is because PE can be deadly. PE can be something that can change the history. That now you see a patient who is talking, in the next 5 minutes, the patient is not talking, it's gone. So it's important to be able to maintain that high suspicion whenever you feel that, okay, the symptoms are not specific, but I'm thinking they might have PE. It's important to maintain the same suspicious. And it's important to remember that as a clinician, your clinical judgment is superior to anything else. Your clinical instincts is superior to anything else. Just work on that and continue with the scoring system. The scoring system, they help us to simplify, but your next slide, please. The approach now. What happens when you have a patient where you suspected PE, and this patient is not in shock? Because as Epi explained in the pathophysiology, PE can lead to a patient to have shock, and this is mostly we're talking about cardiogenic shock. So whenever, before they get to the cardiogenic shock, you're suspecting this patient has a probability of having PE. What are we doing? So if there's low or intermediate clinical probability of PE, do the dimers. The dimer, if it's negative, then no treatment. If they're positive, then you go straight and do CT angiography. And if CT angiography is negative, no treatment. But if it's confirmed, then we have to start treatment. But if you have assessed your clinical and you have that clinical probability of having PE, and your the scoring system is high, then just go straight and do CT angiography. You don't have to go through the left panel where you start by doing D-dimers. So you just go straight and do CT angiography. If it's negative, no treatment or any further investigations. If it's positive, then you continue with treatment. Next slide. So what happens now if I have a patient who is in shock and hypotension, but I'm suspecting PE? If I have a patient who is in shock and I suspect PE, the first thing that I have to do is to do CT angiography. And this should not be delayed in anyhow. Do it, and if yes, it's positive for PE, CT angiography, then you continue with management. Okay? If it's negative, then you should do your echocardiography. So with echo, we'll be able to rule out right ventricular overload. And if there is no right ventricular overload, then you can continue with other causes of hemodynamic instability. But if it's yes, then no other test available or the patient is still unstable, continue with PE-specific treatment, just as empirically, thinking of what next, because sometimes it can be a small emboli that is not visualized that fast, but you should continue with your clinical suspicious that, okay, this is PE. But as we are saying that you have to do CT angiography immediately, does not mean that you should take an unstable patient to the CT scan. You should stabilize the patient before taking them to CT, because the CT won't help you to treat the patient. CT is just there to be able to guide you in the in the diagnosis. But your clinical management or your resuscitation, your ABCs, are the ones that are going to save this patient. So you should still remember that I have to take a patient who is stable to the CT angiography. If the patient is not stable, stabilize the patient before moving them to CT, even if we are saying that we have to do CT angiography immediately. Next slide, please. So there are patients who do not present atypically. They just present with difficulty in breathing. And then this, you can have a probability of PE based on the clinical or your prediction scores. You've done your scores and your scores are either high or low. So if your scores are low, then you have to do the PEC criteria. Remember, I said with the PEC criteria, it helps us to rule out PE. If you rule out PE with the PEC criteria, everything is negative, then you're ruling out PE. But if it's PEC criteria is positive, then you have to do the dimer. And if the dimer is positive, then you have to do CT-PA if it's available, okay? If it's available, then you continue to do it. And if it's positive, we continue with treatment. If it's negative, then you don't have to continue with treatment. We're ruling out. But if your scoring system and your probability is high, then you just have to continue straight to and do CT-PA, okay? If CT-PA is negative, we can continue doing echo, and then we're doing close-up monitoring and repeat evaluation every now and then until the patient is stable enough. Next slide. So I've talked about a lot of investigations, and usually we do a lot of investigations. So we'll try to describe a few of them and the implication in diagnosis, or to be able to give us the clue of PE. So the first one is ECG. ECG is something that you can do bedside, emergency setting, ICU, or in the ward, anywhere we are able to do ECG. And in the ECG, we expect to see right ventricle strain. And this can be seen by this McGinn white sign, where we see there's S1, there's a wave of S in the lead 1. We have a Q in lead 3 and T wave in lead 3 as well. So we see this pattern, we have to think of high probability of having a PE, but also we might have right axis deviation. So once we see this, it's because now the PE is causing the strain or the congestion in the pulmonary, the vessels. So there's a congestion in the right ventricle, will cause the strain in the right ventricle. So once we do an ECG, we'll see those signs. And once we see that, then we have to be able to think of a PE. But the limitation is that it's highly non-specific. So it does not mean if you do it and it's negative, PE is not there. A patient can still have a PE and the ECG is normal. So it means the pathophysiology has not reached to a point where it's causing a congestion and the strain in the right ventricle. So once it's that way, it does not mean that you should rule out. So having a negative ECG does not rule out PE. You can still have a negative ECG and still PE is positive. So this gives a clue or more details for you to proceed doing it. The next thing is the chest X-ray. Chest X-ray is a very interesting, simple investigation that gives us a lot of details. But I'm not sure if all clinicians are able to interpret it fully and be able to get all the information that you get from it. So there is Westmark sign, and this is just a focal leugemia, and this helps us. It has to be done in a upright sitting in the stand-up position, not like the ones that we do in ICU in the supine position or a little bit lateral position, but this has to be in the sitting position. It's where we can see all these signs and be able to interpret that there's real possibility of having a PE. And also we're looking at the pulmonary arteries enlargement because now there's that congestion. So if there's that congestion, usually there's that enlargement of the vessels. So once we see the pulmonary artery enlargement, then we are thinking that there's a possibility of congestion in the right ventricle. So if there's that congestion, there's a possibility of a PE. But again, there are many other things that can cause right ventricle strain. Having things that to, for instance, a patient with a stenosis of the valves, then they can cause the right ventricular strain. So just having these signs that don't mean, that does not qualify or make you think, okay, whenever you see this, it means there's a PE. This gives clue to a patient that you have already categorized and score as high suspicious. You're thinking that there's a high possibility of having a PE. Once you do an ECG and you see that, once you do an X-ray and see that, then well and good, you can proceed. Next slide, please. An echocardiogram, again, it helps us to see the right ventricular strain, so you can also use it. The important investigation is to do echocardiogram. A person who can do it and interpret can see the right ventricular strain, they can see the hypokinesia. And also, remember in the Miller index, where it's saying about the obstruction of the pulmonary vasculature, we can see it in this, that, okay, the lumen is a little bit narrow because of obstruction. Once we see this, then we're thinking of a PE as well. Next slide. Pulmonary angiography is the investigation of choice or gold standard diagnosis of pulmonary embolism. So usually we are trying to see the filling defect of the pulmonary arteries or pulmonary vessels. So this can be visualized by injecting a contrast in the CT scan. So once we inject the contrast, we'll be able to see it. So the only disadvantage is that because this is invasive, the contrast can cause hemodynamic instability or respiratory compromise. And sometimes our patients are too stable, unstable, or sometimes they have already renal failure. So you cannot do much with the pulmonary angiography. But this is the gold standard. It's the test or investigation that you can do, and it can help you to be 110% sure that, okay, there is a pulmonary embolism, because you see the flow in that pulmonary vessels obstructed or there is no flow completely. So pulmonary angiography will help you to be able to determine that. Next slide, please. So having an MRI, doing MRI, it can help you to be able to diagnose, but it's a little bit expensive. It has low sensitivity, and some studies have not validated it to be used. So it's not an investigation that you have to rely on it 110%. No. But if you have it, you can still use it. The dimer, it's a blood test that we do, and it helps us to rule out PE in patients with low risk. So a patient who has a low risk of PE, you can simply do the dimer. That's why on the floors, you've seen that whenever that we are suspecting PE, and you have low suspicious, we do the dimers. If they're high, then you can continue doing CTPA. But if they're low or normal, then you don't have to continue doing CTPA. So it's like starting at the lower side for a patient who have a low probability of having a PE. You can start by doing the dimers. Simply cheaper and even faster for you to get the results of the dimers. The only negative part of it, it's because they can be elevated in other conditions as well. So they can be elevated in a patient with just a DVT, or they can be elevated in sometimes infection. And this cannot be used to rule out, exclude PE in high-risk patients. Next slide. So here we're trying to compare all the investigations that we have been talking about for exclusion of PE. So on the green, it means it's a valid diagnostic criteria. So if you look at the D dimers, on the intermediate, on the high, and PE likely, it's not doing very well. CT angiography is the same. On the high and then the likelihood of a PE, it's plus or minus, okay? VQ mismatch studies, again, they can have normal. On the normal lung perfusion, it's fine. But for a patient who has abnormal lung, then again, it won't be able to give us the results that we want. But doing CT angiogram, then it shows that it's positive for everything. It has high probability in all the cases. It has clinical probability, it's low, intermediate, high, likelihood of PE, everywhere it captures. So it means that's why we're saying it's a gold standard. CT angiogram is pulmonary angiogram. It's the gold standard. So whenever we have a patient that we're suspecting pulmonary embolism, we're at a facility where we have the facility that we can do CT, then it's important to do a CT scan, and we do CT pulmonary angiogram. This will help us to be able to visualize if there's an obstruction or not. Next slide. So what are the principles of pulmonary embolism management or treatment? So we have to remember that pulmonary embolism, it's a cardiorespiratory emergence. So as any other emergence, the principle of treatment is A, B, C, D, E. So we're going with A. You have to secure airway. You have to make sure that it's patent. On the B, you have to make sure that the patient is breathing. On the C, you have to make sure that the patient is as well hemodynamically stable. Okay? So whenever we have high index of suspicion in any patient, it's important to order and initiate appropriate management early, as soon as possible, because any delay can change the outcome of this patient. And a patient who has a pulmonary embolism warrants an admission in ICU, HDO, and sometimes even in emergency departments. So you can be walking and suddenly you have been having a DVT and you're walking and suddenly you're having difficulty breathing. You just have to run and rush this patient to emergency departments. It's not a patient that has to stay in the queue, wait in the line to see a doctor on the clinic schedule. No, this patient needs immediate emergency services. And management of pulmonary embolism, remember, it's a multidisciplinary approach. It does not need just one man show, but it needs multidisciplines. So you need a pulmonology to come in place. You need sometimes a surgeon to come in place, a physician to come in place, hematologist sometimes to come in place, because we might be talking about multifactorial factors that can cause this pulmonary embolism. So we want each input to be able to help us in the management of this patient. We have to remember to follow the ICU protocols. So the fast tag BID, we have to make sure that we are following so that the patient can get the best care out of it. And this patient needs continuous monitoring. That's why this patient should be admitted in either ICU or HDU, where there is continuous cardiorespiratory monitoring. That means ECG, heart rate, the saturation, the blood pressure, and respiratory rate. Okay. Once we have done all that, because that's the life-saving, then we can come to the respiratory management, hemodynamic management, anticoagulant thrombolytics, IVC filters, and catheter endolectomy. We'll look each of it in details in the next slides. Next slide, please. Respiratory management. So remember ABC. So this will take A and B. So on the A, we're thinking about, we want to make sure that this patient is not hypoxemic. They have to be maintain a little bit of hypercapnia and also the PEEP effects. So we have to remember, if the patient has come to a stage where they have cardiogenic shock, the hypoxemia will worsen. If you happen to put them on the ventilator and you have your PEEP, all these will affect your hemodynamics. So this is something that we have to be able to think that these will worsen their hemodynamic collapse. So it's important to initiate less invasive or non-invasive, like high flow nasal cannula or non-invasive mask, while we're waiting for the breaking of that clot to set in. Because that clot is there, it's causing obstruction. This results in a congestion. So remember that once we put the patient on mechanical ventilation, we are increasing the intrathoracic pressure. So we are compromising the backflow of blood to the heart, which will worsen the blood pressure, will worsen our hemodynamics. So it's important to consider that I don't want the hypoxemia. I don't want this patient to suffer any way of not having good oxygenation. Then I'm putting them on oxygen. I should not rush to put them on a mechanical ventilation. If needed, and I'm reaching to a point where I have to put them on a mechanical ventilation, then I should be able to avoid the PEEP, because now again, I'll increase the intrathoracic pressure more. I should be able to avoid the high tidal volumes, because again, I'm increasing the tidal, I'll still be obstructing the backflow of blood. So on this particular point, once I'm putting a patient on mechanical ventilation, it's important to be able to make sure that I'm oxygenating, but I'm minimizing. I'm going with less and less. I'm not rushing to make high PEEPs to make sure that I'm oxygenating to the maximum. Give time for the thrombotics to take place to break the clot. And now that will help you to improve your hemodynamics. Once you have better hemodynamics, then you can maximize your respiratory settings, your ventilator settings, because now your hemodynamics are stable. Okay. Next slide. So on the C, where we are thinking of hemodynamic management, so we have to start IV fluids, but now again, how much are we starting? So it's important to be guarded. We shouldn't be judicious to give a lot of fluids, because now this patient has a risk of right ventricle dilatation and dysfunction as well. So once we give more fluids, we might worsen or fasten the way to get worse. So we give fluids, but we have to be judicious on the way that we are prescribing the fluids. So in order to improve the hemodynamics, we might need to start the vasopressors, okay? The ideal vasopressor in cardiogenic shock due to PE is unknown. We know with the cardiogenic shock, we prefer to start with the dobutamine and the Mirion and the likes. But in this case of a PE, then we don't have the ideal one that we know. You can start the noradrenalines because they increase right ventricular functions by inotropic effect, and also they can improve the coronary perfusion. So it's good to start with noradrenaline. Dobutamine has been shown worsen hypotension because of the vasodilatation effect. So we don't have to start with the dobutamine, which in a normal cardiogenic shock, we usually like to start with dobutamine. We can give nitric oxide if we have, and this will help to reduce the pulmonary vascular resistance and ventricular afterload. So this will help also to help with the hemodynamics. If we have it, we can start nitric oxide. Next slide. So the important treatment now, it's anticoagulation. So anticoagulation, any patient that we have confirmed to have a PE and they have no contraindication should start anticoagulation immediately. And this, again, we have to give appropriate anticoagulant therapy according to the patient. So if your patient has a renal failure, you should be thinking, okay, I should not give enoxaparin, I should just give heparin, because now enoxaparin will worsen my kidneys. So you should be able to think of the patient holistically, not just the PE that you're dealing with at that particular time. Think of a patient holistically and approach it that way, okay? The patient has a history of heparin-induced thrombocytopenia, then again, you should not give heparin, because now you start getting thrombocytopenia. You should think of other medication that you can give. And anticoagulation, as Epi discussed in the vitreous triad, with the anticoagulation, it helps us to prevent that hypercoagulability state, because the body, the way it is, once you have a clot anywhere, it gets into cascade of forming more clots. So we want to prevent forming any other more clots. So we can have a PE that it's small, but if you don't start anticoagulation fast, then we might lead to that even clot becoming bigger or larger, or throwing a clot somewhere else. So we want to prevent that from happening. That's why we are initiating anticoagulation. Okay, so we can use all the anticoagulant that we have at the right dose to help treat the patient. Next slide. So the treatments, actual treatment now is this, thrombosis. And on the thrombosis, you want to break that clot that has been formed in the pulmonary embolism. So there are various ways that we can use. We can use fibrinolytic agents in addition to heparin, and this will help us to break the clot. So again, this it has to be in a setting where we can monitor the patient closely, because that's why I said these patients have to be in either ICU or HDU. Because with breaking or any fibrinolysis that can start, it can lead to other complications of breaking the clot. But if you have drugs like streptokinase, Arteplase, we can give them. And this will help us to break that clot. And once we break that clot, this will help us to heal faster the lungs and will improve the perfusion of the lungs. And this will, the patient will improve. So if we are able to have the thrombosis fibrinolytic agents as streptokinase, Arteplase, then it's important to start them initially in the first 24 hours, okay? And if the patients have stayed more than 24 hours, sometimes the studies that show that even starting the fibrinolytics does not improve the outcomes, okay? Next slide. So the benefits of starting a thrombolytic, it's a rapid resolution of symptoms. That means the patient will start breathing okay, there'll be less chest pain, they'll have less distress. And it improves the cardiorespiratory system, as well as the patient who is already on mechanical ventilation might not need to get to the mechanical ventilation. And also it can improve the right ventricular function. So if the damage was to happen, it can reduce that damage from happening. So it helps in all the ways possible. But again, I've said you have to be in a setting that we have to monitor, because we are breaking, so we are preventing the blood from clotting. So these patients, they can tend to bleed. So they may end up getting intracerebral hemorrhage or any other minor hemorrhages. So they have to be in a hospital setting where they are monitored closely. They don't have to fall, they don't have to injure themselves, because all that happens, they're at the risk of bleeding out. So you need to be in a setting where we're giving fibrinolytics, but we're monitoring this patient closely, as we want to help them, we don't have to cause any other further damage. Next slide, please. So this is a surgical way of removing the clots. Basically, it does not mean that we are cutting, but it's invasive, and we do it in the cath labs, where we are using, inserting the guide wires, the wires, and getting to the clot and breaking the clot by removing it. It's called catheter embolectomy. So we can, this is either by breaking it in small fragments or removing it, all of it. And it's for patients who have to be stable, okay? So you cannot take the patient who is unstable. Sometimes it's not very easy. If they're unstable with massive PE, then, and you have tried the fibrinolytics, it's not working, then we can consider the catheter embolectomy. It's like the last resort, but the first treatment should be the fibrinolytics that you're using. For patients who have low risk of PE or submassive PE, then they don't have to go through all the catheter embolectomy. We believe by giving just the fibrinolytics, they can work and help this patient recover without any problems. But for patients who have unstable, they have massive PE, then it necessitates to start to consider getting them to catheter embolectomy. Next slide. So after we have treated the patient, or a patient who has a DVT and is drawing clots, it's important to consider putting an IVC filter. So this is a preventive way to prevent further clots going to the lungs, to the pulmonaries. So we put a filter in the inferior vena cava, and this will act to prevent the clots from flowing to the heart. So for patients who has a DVT or a patient who has a PE, may require permanent IVC filters, okay? So this will help them to live longer without experiencing the complications of a PE again. So any patient who has a high risk, a patient who has a DVT, then it's important to consider putting a permanent IVC filter. Next slide. So if a patient is in the hospital, and sometimes we get PEs for patients who are in the hospital and did not come with a PE. So how can we prevent patients who are in the hospital and don't have PE from getting PE? So one is to encourage early embolization, mobilization and ambulation. So a patient should not lie in bed from morning to evening every day, unless they necessitate to be in bed that much. But otherwise, we should encourage our patients, whenever we are passing the rounds, whenever they're in the hospital, to mobilize. And if they cannot walk still, then even a mobilization bed to chair or on this bed with just a physiotherapy, that can help to prevent the clot formation. The stasis that we discussed on the pathophysiology will help to reduce that stasis and allow the blood flow. So physiotherapy is one part as well. So sometimes for ICU patients who we know that they're not moving out of bed anytime soon, we can consider putting the elastic stockings or DVT stockings, famously known as, and this will help the stasis, will also prevent the stasis formation. So it continuously encourages the blood flow. And even better, some studies have revealed that, okay, the stockings may not work efficiently. We have what we call intermittent pneumatic compression stockings. And these are intermittently inflating and deflecting. So once they do that, it means they're trying to act as the muscles of the legs. As how we walk and mobilize our muscles, it's how the blood is flowing. So the IPC or intermittent pneumatic stockings, compression stockings, they work under the same mechanism of physics behind. That they'll be compressing and releasing a bit after certain time interval. And that will help the blood flow. But also involving the patient. We don't just have to manage the patient without educating them. So once we educate them the risk at hand, we educate them on the preventive measures, they'll be able to take necessary precautions. And once they take necessary precautions, then it also helps us to prevent the DVT from happening. Also, we can consider putting on prophylaxis. So for instance, on the fast-tag BID of the ICU management protocol, one of it is thromboprophylaxis, that we are preventing the thrombus. So any patients who are admitted in ICU, we usually get them on a thromboprophylaxis. That can be enoxaparin, heparin, any medication to make sure that we are trying to prevent the thrombus from formation so that the patient can be safe. As well as avoiding oral contraceptives or long flights. If they're taking long flights, then they can be on maybe on junior aspirin. And all these will help the patient. If they're taking long flights, they should be able not just to sit, but okay, once they're in the flight, they can walk, take some interval and walk. In the aisle in the flight, there's no problem. That will help them to prevent or minimize the possibility of getting the clot. Because we have seen one of the risks is immobilization for quite some time. As well, important thing is to screen for population at risk. So you have a cancer patient, you have a patient who you suspect that they might have that. It's important to screen them before the PE happens. And the screening helps us to prevent it from happening. It helps us to manage it earlier. So it's important to do the screening because it will help the survival of this patient, to improve the survival, apart from just waiting to treat the condition once it happens. Next slide, please. So sometimes it can be difficult for us to differentiate the PE from other diagnoses, and we can have a list of differentials. Things like pneumonia, acute respiratory distress syndrome, acute coronary syndromes, cardiogenic shock, sepsis or septic shock, heart failure, even pneumothorax, because some of the symptoms mimic each other. So a patient will present with the same, difficulty in breathing. And a patient who has pneumonia can present with difficulty in breathing. A patient who is in cardiogenic shock, they can still present with difficulty in breathing. A patient who has pneumothorax may present with difficulty in breathing. So we can see that the list of differentials is long, but the scoring system can help you to think of PE or not. So it's important to remember the scoring system. Next slide. So, low index of suspicion due to presumed low prevalence. These are the factors that they make in our setting to be able to miss the PEs. We have limited diagnostic capabilities. I don't know about other people's countries, but I would say maybe for my country, not every hospital has a CT scan. So sometimes you can get a patient and even if you think about it, you cannot still conclude, make a diagnosis because you don't have a CT scan. And we lack training and specialized human resources. Sometimes we have limited treatment options leading to immobility. Not every hospital can be able to have all the fibrinolytics, so that at times you might see a patient with a PE, but you don't have a fibrinolytics, or you don't have the human resource who is trained to be able to know the precautions needed to use the fibrinolytics. So they end up having fear of using fibrinolytics. At the end of the day, the patient can still pass away because we are limited in the resources. And sometimes, as I've stated in the first slide, we have a list of differentials. So it becomes difficult sometimes to focus on the PE because we have more obvious condition. A patient presenting with difficulty breathing, we're thinking of pneumonia because that's the most common thing that is happening in our community. So sometimes we forget PE, or we think it's something that is far-fetched. But in reality, it's something that is happening real. And lack of protocols or awareness that in the hospitals we don't have proper protocol of PE management, and we're not aware of how PE can cause mortality or contributes to the mortality. As Epi started initially, we said, okay, most of the diagnosis of mortality, the cause of PE as mortality is found in the autopsy, the pathology after the patient has passed away. Once we are doing the autopsy, that's when you discover, oh, this patient died because of PE. That means we did not make that diagnosis before the patient passed away. So it means we lack awareness and we lack that thinking of PE. We feel like it's far-fetched diagnosis. So lack of appropriate infrastructure of management of these patients. As I said, not every hospital has a CT scan. Not every hospital has an ICU for these patients. So you find that, okay, you can make all the diagnosis, you can be able to help this patient, but you don't have that facility, or the infrastructure does not allow you to do all that. And at the end of the day, you're missing the diagnosis, or sometimes you're getting the mortality because of all that. Next slide, please. So in conclusion, PE is a highly fatal cardiorespiratory emergence and a common cause of sudden cardiac arrest. If you remember all the causes of cardiac arrest, the T's, there's a thrombus, and then on the thrombus, it's where we're thinking of the PE or MI. So we should always think of PE as one of the fatal things and treat it as true emergence. And the prevalence is likely to be higher than documented, especially in low resource settings, because we don't diagnose, because we don't have the facilities, we don't have the imaging, and we don't even do that autopsy that much to every patient, because I believe if you're doing autopsy for every patient, you might find that even the prevalence is going up. And challenges exist in many clinical environments which hamper the diagnosis and treatment interventions for PE. But we have to overcome all the challenges that we are facing, and that's the essence of having the CME in this discussion tonight. And effective use of the scoring, clinical scoring system may lower the diagnosis, or they may help us to lower they may aid us to lower the probability of getting the PE diagnosis. So whenever you're thinking of the PE, it's important to use the scoring system, because the scoring system might help us to get the diagnosis of PE fast, and sometimes can help us to not do unnecessary imaging on the patient when you don't need to. And advancement of diagnostic techniques such as CT-PA, MRI have improved the diagnosis and accuracy of getting the diagnosis. Early recognition and a high index of suspicion remain the key in improving the outcomes of PE. So as a clinician, you should have that instinct of thinking of PE whenever you see a patient. because that suspicion is what will lead you to score the patient. It's what will lead you to do the imaging, and it's what will lead you to make that diagnosis and treatment. But if you have low suspicion, then we cannot opt to catch the PE fast or treat it proper. Next slide. Enhance awareness for recognition of life-threatening emergencies such as PE. It's important as physicians and doctors to participate in telling our other colleagues and discussing these topics and forums in the CMEs and in our clinical meetings so that we can enhance the awareness. And we should be able to apply and use the available protocols for management of emergency conditions such as PE. There's clinical scoring system, and we should strengthen the clinical networks and mentorship to enable remote consultation and supervision for the management of complex emergencies. So things like WhatsApp groups, telemedicine are coming into place to help us to be able to assist even people in the interior regions where they don't have the facilities or where they have limited resources, to be able even to give them guidance with our knowledge and all the things that we have in other places. So we should be able to do remote consultations and sometimes mentorship, even sometimes to visit them and see what they're doing and encourage them. And that will help us to be able to catch this diagnosis and help the patients. So once we do that, the sky is the limit for us to improve the outcome of the PE to all our patients that we're serving. Next slide. Is there any question? Feel free.
Thank you very much, Dr. Roger, for the nice presentation. That was a wonderful, clear presentation. At this time, we encourage our participants, as we said earlier on, to use Q&A for questions or the chat box. It has been very interactive on the chat box. Thank you for active participation. Once we give you time to write your question on the Q&A, let me welcome the Honorable Professor Ambassador Poki, who's the president for the CANEXA. We are so proud to have you among us. Would appreciate if you take 1 or 2 minutes and address our participants to encourage such clinical activities in our region and all over in the world. Please, you can unmute yourself.
All right.
And talk to us.
Oh, thank you very much, Dr. Ntambwe, for affording me the privilege of talking to this august body of professionals. I want to thank Gradient Health for the journey that they have walked with us ever since they came into being, and ever since they realized that education is the best way to sell their product. Please keep walking that journey. The topic that was presented this morning, my side, on pulmonary embolism, I need to commend Dr. Happy and Rogers for the work that they've done. They've done a very, very good job on a disease that is very elusive. I call it an elusive disease syndrome. This has claimed and continued to claim lives of many patients. This presentation was very well researched, and the citations of examples that were cited were very relevant. Kudos. However, it was very long, 60 slides together with a lecture behind it, only 25% may stick with us. I think we need to come up with a system that after such a lengthy presentation, then the presenters come up with action points. I recently visited a hospital in the US, and I had an interaction with an anesthesiologist, and I was surprised that on their identification badges, they have a small laminated piece of paper with what needs to be done when there is malignant hyperthermia. It is at the point where you simply pull, read, and do. I'm not saying every presentation will need something like that. Then we shall be carrying maybe a kilo of such references. But I think if a page or two of a summary of what needs to be done when something like this is suspected will go a long way to help people retain information that they have been given. Number two, those of us that have listened critically towards the end have heard what Roger said. Not all facilities will have the health commodities to effect intervention in the textbook method. This calls for customization of interventions based on knowledge at the back of our minds. But also we need to establish synergies with emergency medicine, radiology, and those that we work with from day to day, the surgeons or orthopedic surgeons for that matter. We also need to be smart to give advice with caution. We need to know what can be done and what can't be done. Now, Rogers has just told us that, when you are exposed to a long haul flight, you can stand and walk in the aisle. My brother, these days of COVID-19, we are hardly allowed to go to the restrooms. So that may not be working very well. Maybe this should be advised to wait till they are stable enough to start engaging themselves in walking. However, the compressive stockings, together with blood thinning agents, could help us in trying to advise these patients who are traveling seriously. Now, we need to know that in our environment, continuous professional development is the best tool to keep us informed, irrespective of the setting where we are placed. Clinical acumen, or what Dr. Roger Swai has said, suspicious index, can only be implemented from a position of knowledge. You can only question what you have in your mind. If you don't know, the symptoms will just be presenting themselves and you'll be wondering, is this a new disease that I'm seeing in this patient or what? So my brothers, my sisters, let us work together to allow us to know what to expect. And when equipment comes, this will just be helping us. It will simplify the work that is at our disposal. I trained in India, where I was taught that they only had chest x-rays for investigation of heart ailments. They only depended on what they would see on the radiograph and a little bit of ECG. They did an amazing job. We too can adapt a similar approach, but we cannot do it without exposing ourselves to knowledge such as what has been presented, so that we have a bank of questions that can help us to ask, what else can present like this? What can I do? Do I need to put a PEEP in this case? And what would be the consequences if PEEP is added to this mechanical ventilation in a patient that is not saturating very well? I think I should pause here and allow the presenters to respond to the questions that have been presented. And thank you once again for allowing me to say a few words. CANEXA is here to support development of human resource for health in the region. We recently have had Namibia, DRC come on board together with other founding member countries, and we are looking forward to welcoming Ethiopia to join in the bandwagon. So the sky is the limit. We may not be richly endowed in resources. I thank God each one of us contributes to the pool of endowment in brain power. God bless you. Thank you so much. Bye-bye.
Thank you very much, Professor Ambassador. We appreciate your comments and we value them so much. We'll take into that consideration all your suggestions. And the next time when we're in need of any CANEXA member to come on board to present, we'll contact you so that you can direct us to the right person.
You're more than welcome. Thank you so much.
We continue. I'm checking the question and answer here. There's a question. Are there any empirical management protocols that you can recommend as the initial management and the medication as pending? Roger, will you want to take that one?
Pardon, can you repeat the question, please?
And when you check the question and answer box, there's a question that said, are there any empirical management protocols that you can recommend as initial management as investigation are pending? Basically,
So
our
I'll say,
colleagues want to find out if there's any protocols that can be put in place so that they can follow as they are trying to do other costly or non-available investigations at the institution.
so I would say the protocol is like the emergence. It's an emergence protocol, ABC. So you have to make sure that your patient, you're maintaining the airway, the patient is oxygenating, you're putting your patient in IV fluids, trying to maintain the blood pressure. Hemodynamics are being stable. You don't want to start any thrombolytics without being sure that there's true pulmonary embolism. So you have to wait until you get the results, then that's when you can start the treatment. But before that, you can do the supportive treatment.
Thank you very much. Unless if there's any other question or comment
Dr.
from
Papicho,
the
just a quick one.
panelists. Yes, please, Dr. Ndaba, go ahead.
I just wanted to add to Dr. Rogers's very accurate response. Really, for every emergency, I think you will never go wrong by using the principles that we already know. And like Dr. Rogers mentioned, the principles are always airway, breathing, circulation, before you reach your definitive management. In most cases, and in our centers, low resource centers, we do not have facilities for us to make accurate diagnosis within the shortest possible time. Normally, we are able to diagnose probably after maybe a day or so of investigations. That's when we know what exactly is going on, especially in our resource constraint facilities. So just to emphasize again that the principles of resuscitation apply in all emergency conditions. That is life-saving. You need to keep the patient alive, irrespective of the diagnosis, once you apply those principles. And so the emphasis really is resuscitation, and resuscitation happens even in the absence of knowing what exactly is going on, because the systems that will always be embarrassed in almost all emergency conditions would be your airway, and you're very worried about your airway because lack of oxygen within a few minutes, the patient will die. Your breathing, and also the circulation. I think these are the key systems that you really need to optimize, focus on as you look for what is really going on. Your patient will be kept alive. So in terms of empirical treatment, really, in an emergency setting, you have your airway, breathing, circulation, really to prioritize almost all the time. Thank you, Dr. Papicho. I just thought I re-emphasize on what Dr. Rogers had mentioned. Thank you.
Thank you, Dr. Ndaba. And there's another question on the Q&A. They said, what should be your consideration during induction if patient needs invasive respiratory support? Wow, wonderful question. For this patient who's already hemodynamically unstable, respiratory distress. Dr. Asbeth, will you share with us your experience, please? Yes, so with relation to the question,
can you hear me?
Yes, we can hear you. With relation to the question in the box Q&A, where they say, what should be the consideration during induction if patient needs massive respiratory support? Would like to hear your experience. How will you take care of this question?
Thank you very much. So, and thank you very much for the whoever asked the question. So if you read previous document papers, they will say, so they are recommending the cardiothoracic anesthesia to be the one to be available during the induction, because there are so many considerations. So basically, with the experience, I would say first of all, it's most of the time it's an emergency, so we always go with the rapid sequence induction. But on the drugs, I would say we optimize. We make sure we use drugs which will make sure you don't end up with the cardiovascular collapse, which means you titrate your drugs well, and you make sure you have whoever is assisting you should have a very experienced, and whoever is intubating should have very experienced. So there's no room for error. So that you make sure you if possible, you use you make sure you give an induction drug and the patient is well anesthetized, but also you can attempt and make sure you don't give so many drugs to make sure you end up with the collapse. So I would say, in summary, make sure whoever is doing the intubations of experience, make sure you have an experienced assistance. Make sure you choose wisely your drugs. You said before, remember this person has got obstructive. Actually, they're almost having obstructive shock. So even choice of the induction drugs has to be well. So you don't need to give Saupen to maybe 500 or whatever number you are using for induction. These are the one maybe you may end up using like ketamine, or if you have any other drug which has got less cardiovascular issues. And I would say also make sure you oxygenate well. Remember, as we have discussed the role of oxygen, but also emphasize to make sure the patient is well. I think that is my suggestions.
Thank you very much, Dr. Asbeth, for that wonderful word of experience and knowledge. I think for now, there's no more question, and looking also for the interest of time. Before we close it completely, I'll hand it back to Mariam, who's on the other side of the panelists, to take it up there. Until now, for me, we'll meet you next year for other webinars. Mariam, please.
Thank you so much, Dr. Capiccio. I'll actually turn it over to Magdalena, my colleague at Gradient Health Systems, to close out our final webinar of the year.
Thank you all for joining. Special thanks to Honorable Ambassador Professor Mpoki. Thank you very much for joining. We are really humbled by your presence in this webinar. Mine is to wish you happy holidays, and please don't forget to send out your questions for discussions. We shall be looking into this. We shall continue these webinars next year. So if you feel like you need a topic for us to be discussing, please don't forget to send it to our email, customercare@gradienthealth.org. And also for those of us who are working with hospitals where we have our Gradient Health critical care machines, the ventilators, and also the anesthesia machines. Please always feel free to reach out to us via email or our Safaricom number. That is our Safaricom number. That is on the website. It's also WhatsApp. From anywhere we can respond whenever possible. For any technical issues, queries, for those who would like to have our machines, any queries you would like, please reach out to us via WhatsApp, via email, and all. Yeah, thank you all. And mine is to just wish you a pleasant and good, happy holidays, and see you next year. Thank you.